But without delaying any further, I just wanted to start my talk saying that the current WHO 2017 classification of hematolymphoid neoplasms is essentially based on biological and clinical relevance. So there is nothing called, there is no entity which I can dissect out saying that this is what it is important and that the others are redundant on. So, however, to have much more areas of our interest or to concern to us, I had focused on selected areas of lymphoma pathology where it really has an impact on decision on first-line chemotherapy and maybe in prognosticating the disease in a significant way. Well, to say that, not to scare everybody, just to highlight that the current classification of mature B-cell lymphomas, this is what the list is quite lengthy, and it is not possible or it is beyond the preview of this talk to go into the details of each of the entities. Same with T-cell lymphomas, there are quite a numerous entities which is each was considered to be a distinct biological subset. So to have much more crisper way of talking, I've selected a few areas where it might possibly, as per me, it has an impact in clinics as well, especially when you're dealing with Hodgkin lymphoma or in certain situations whether you want to distinguish the Hodgkin lymphoma with the NHL, where you have a difficulty where you need to have a kind of a awareness and the knowledge to diagnose accurately, and dissecting out the high-grade B NHLs both for diagnostic treatment and prognostic relevant entities, and few areas on T-cell lymphomas. Well, to start in Hodgkin lymphomas, what is it like? It has got diagnostic challenges. You've come across with a different literature and different viewpoints. What should be the ideal panel of IHC markers you should use it? The panel which has been suggested in the screen right now is what I feel it is required. When you have a classical histology and classical clinical presentation, a basic panel of 3, 20, 15, 30 is enough to make a diagnosis of Hodgkin lymphoma. However, in most of the situations, there is there is some kind of disconnect with the clinical conditions, and we as a pathologist, we may not be knowing the complete clinical profile. There is my advice will be to use an optimal panel which will be including PAX5, EBV, LCA, Octobovin, and GATA3. In cases of certain special situation, you can use an extended panel. We'll go through it in subsequent slides. Well, before we go into the diagnosing of lymphomas, one has to be very aware of certain aspects in clinics. Is Hodgkin-like features can be seen in many of these EBV-associated lymphoproliferative conditions, and also some kind of immune suppressive or immune compromised states, especially post-transplant setting, or in case of long-term medications such as methotrexate or anti-TNF medications, where it will be the histology will be exactly like a typical Hodgkin lymphoma. So in those kind of situations, if the clinical side is not going to give you the adequate details, will be extremely difficult to identify that kind of a Hodgkin mimicker with certainty. So once you have this area of lymphoma, what are the areas of clinically relevant diagnostic challenges? As per me, I've dissected a few areas. It's important to dissect out Hodgkin lymphoma, classic Hodgkin lymphoma with diffuse large B-cell lymphoma, especially the syncytial variant of nodular sclerosis and lymphocyte depleted type poses the greatest diagnostic dilemma to DLBCL. And in cases of mixed cellularity and lymphocyte-rich variant, especially the diffuse variant of lymphocyte-rich subtype of classic Hodgkin lymphoma, can pose diagnostic challenges to distinguish from T-cell histocyte-rich B-cell lymphoma. And in case of mediastinal location, to distinguish between Hodgkin lymphoma and primary mediastinal B-cell lymphoma, Hodgkin lymphoma with gray zone, currently identified as B-cell lymphoma unclassifiable with features intermediate between DLBCL and classic Hodgkin lymphoma. Sometimes you have a problem with distinguishing classic versus nodular lymphocyte predominant Hodgkin lymphoma, and few instances where it can have challenges to distinguish from ALCL and AATLCL, like angioimmunoblastic T-cell lymphoma. When you have a problem in distinguishing with DLBCL, what should be both the clinical side as a pathologist should be having an appropriate panel of markers should be used. My suggestion would be like an LCA 320, 315, 79 alpha, EBV, MUM1, OCT2, BOB1, and TCL6. Panel will help you in distinguishing the subtypes further. So this is the panel which you can, this is my suggestion, the extended panel can be used beyond it. If you go into it, a lymphoma cell or a neoplastic cells with intact B cell differentiation program like CD20, 79 alpha, PAX5, OCT2, BOB1 positive will be unlikely to be of classic Hodgkin lymphoma. It has to be B cell, non-Hodgkin lymphoma more likely. And in cases with EBV positive with a retained B cell differentiation program, you are maybe looking into a EBV positive diffuse large B cell lymphoma. In comparison to neoplastic cells of DLBL, Hodgkin-Reed-Sternberg cells are usually 1530 positive, they are LCA negative, rarely can be 79 alpha positive. Even if 20 positive, they will be variable and weak, and PAX5 will be dim positive. So these are the certain features which you can take it in distinguishing between these two entities. But few points which need to be remembered in distinguishing in instances where classic Hodgkin lymphoma and DLBL are a differential. Expression, you need to know that expression of BOB1 in Hodgkin lymphoma is more common than OCT2, but both the marker expression is unlikely or very rare in classic Hodgkin lymphoma. When you have a neoplastic cells expressing both BOB1 and OCT2, probably you're not looking into classic Hodgkin lymphoma. MUM1 can be used as a very sensitive marker of Hodgkin lymphoma, though it may not have a very good positive predictive value, but the negativity, if you get a negative, then you need to reconsider the diagnosis of classic Hodgkin lymphoma. Yes, in many instances, you keep hearing about LCA, but the tricky of LCA is the difficulty in interpretation because it is usually surrounded by other lymphoid cells. So sometimes it becomes very difficult to know whether the positivity of the membrane of the Reed-Sternberg cells or the adjoining or the background lymphoid cells. So one of that such DLBL is primary mediastinal or primary thymic B cell lymphoma, which you have most of the common diagnostic challenges in lymphoma pathologies in mediastinal masses. Why it has a problem? So one thing is that because of the limited material, because of the core biopsy predominant sample being the core biopsy, and also the overlapping biological properties of classic Hodgkin lymphoma and PMB cell poses the diagnostic challenges. So if you use this kind of some kind of a panel which, in addition to the panel we talked in the classic Hodgkin lymphoma, if you add CD23 and 79 alpha, P63 and GATA3, most of the time you will be able to come to a diagnosis to know whether it's a PMBCL or classic Hodgkin lymphoma. PMBCLs are B cell lymphomas which intact pan B cell markers, the expression of pan B cell markers at about 20, 79 alpha, PAX5 positive. In addition, you will get 23 positive and you get weakly or focally positivity for CD30. So here, you need to understand, 30 positive is more stronger in Hodgkin lymphoma, whereas in PMBCL, it is weaker or variable positivity. So few addition of markers, like if you add P63 and GATA3 to the panel, your diagnostic accuracy will increase. The primary mediastinal B cell lymphoma is now shown to be positive for P63, whereas GATA3, which is a T cell nuclear transcription factor, is usually negative in primary mediastinal B cell lymphoma, whereas usually in mediastinal Hodgkin lymphoma, GATA3 positivity is higher. So the combination of P63 positivity and GATA3 negativity is a good way of predicting a PMBCL and distinguishing PMBCL from classic Hodgkin lymphoma. And also at the same time, when you have a co-expression of 15 and EBV, either EBV, LMP or EBER, is also a good way of identifying classic Hodgkin lymphoma. Mind you, MUM1 cannot be used to distinguish between these two because MUM1 expression has been shown both in classic Hodgkin lymphoma and PMBCL. BCL6 expression is more commoner with PMBCL, but we can't use it to separate it out or dissecting out because many times classic Hodgkin lymphoma can also be positive. So one is primary mediastinal B cell lymphoma. What is the other challenges will be in the mediastinum is commonly is a gray zone, mediastinal gray zone lymphoma, which is now termed as or called as B cell lymphoma unclassifiable with features intermediate between DLBCL and classic Hodgkin lymphoma. This is a B-cell lymphoma, listed under the B-cell lymphoma classification in current WHO classification, which has got an overlapping clinical, morphological, immunophenotypic, and as well as genetic features of both classic Hodgkin lymphoma and diffuse large B-cell lymphoma, especially the primary mediastinal B-cell lymphoma. So, what is this entity like? If essentially this is an entity which has been defined for those situations where there is a discordance between that cytological appearance and the immunophenotype. That is the one. So you can have an Hodgkin-like morphology, but immunophenotype of PMBCL, or whereas PMBCL-like morphology with an immunophenotype of Hodgkin lymphoma are the ones which form this gray zone or gray zone lymphomas. Essentially, you need to remember, like, these lymphomas are usually negative for EBV. So EBV positivity is a good sensitive marker to pick up as a possibility of an Hodgkin lymphoma. Necrosis is frequent, but unlike in classic Hodgkin, especially necrosis can be seen in nodular sclerosis subtype of classic Hodgkin, especially type 2 type, whereas in those areas, necrosis usually contain neutrophilic infiltrate. However, in the gray zone lymphoma, they don't contain neutrophilic infiltrate. These are subtle soft points, but we can't take hard and fast about it. So due to the variation in histological pattern and different portions of the tumor, diagnosing these lymphomas and core biopsy will be challenging and sometimes not recommended. Therefore, it's important to have a good clinical correlation. Like, essentially, I wanted to stay and emphasize one point here. There are mediastinal lymphomas which can be a composite. Like, we can have an areas of Hodgkin, you can have an areas of DLBL, or maybe metachronous kind. It might have presented with Hodgkin lymphoma and relapsed with it's like morphology of PMBCL. Those lymphomas are not included under this mediastinal gray zone lymphoma. They're kept it as a separate entities. These are the two pictures. Like, when you have an Hodgkin-like morphology, the picture is up. Like, you can see this. This is a positivity of CD20, diffuse strong positivity. These are the cases you can call like gray zone lymphoma. Whereas you have a sheet-like large cells with clearing around with fibrosis, but showing strong positive at 15 is unlikely to be typical of PMBCL. These are the lymphomas which you can consider to be as gray zone. Why is it important to identify this gray zone lymphoma? Because they are shown to be worse prognosis than classic Hodgkin lymphoma and PMBCL, even poor responders to the frontline chemotherapy. So if you want to see what the reason of identifying this gray zone lymphoma is, you have to see that both PMBCL and mediastinal nodular sclerosis classic Hodgkin lymphoma, they have very closer histology and clinical profile and gene expression profile, more of a similar immunoprofile. I don't want to go into it. So essentially, this is a typical entity of a gray zone where it transitions. It is in the transitional zone between the large B-cell lymphoma, diffuse large B-cell lymphoma, and classic Hodgkin lymphoma. So when you are evaluating this fibrosis pattern kind, it is more commonly seen in mediastinum. Yes, this gray zone lymphoma described in non-mediastinal location, but that is predominantly picked up by gene expression profiling, but there is no kind of definite way of picking up by immunohistochemical evaluation. So my point is, whenever you are identifying a gray zone kind of lymphoma in a non-mediastinal setting, you should be very careful. That your error or kind of thing should be more towards the NHL side. Okay. So this is what I have listed out. I don't want to go further. This thing, this picture. So salient points to remember is when you are addressing these gray zone lymphomas is, so cases when you're diagnosing some entity as a mediastinal gray zone lymphoma, especially with CD20 negativity, you need to have a typical morphology of PMBCL. So those cases which are typical PMBCL-like morphology with CD20 negative only should be called as gray zone lymphoma. At the same time, when you have a typical morphology of nodular sclerosis or Hodgkin lymphoma with focal or variable positive CD20 also should not be called as gray zone lymphoma. They should be called as Hodgkin lymphoma. Similarly, when you have a Hodgkin-like lymphoma, however, with retained B-cell immunophenotype of positivity for 20, 17, and alpha, the transcription factor of OCT2 and BOB1 and PAX5, then the gray zone lymphoma should be considered. And one point to remember is EBV positivity of gray zone is extremely uncommon. EBV positivity suggests that is possibly you're looking at some variants of Hodgkin lymphoma. Presence of necrosis should not be considered that it is a part of gray zone, because you can see a necrosis in Hodgkin lymphoma also. However, you can pick it up by using an extended panel of IHC where if it is typical pattern of PMBCL or Hodgkin lymphoma is emerging or not. So that is about your distinction of classic Hodgkin lymphoma between PMBCL and gray zone lymphoma. Well, nodular lymphocyte predominant Hodgkin lymphoma. This is other subtype, other type of Hodgkin lymphoma. And some instances, yes, you have challenges both for classic versus nodular lymphocyte predominant. The basic essence is in both these entities we need to understand is NLPHL is typically a B-cell lymphoma where the B-cell differentiation program is retained or maintained, whereas in classic subtype, it is of variable and aberrant. So you don't get any T-cell markers in NLPHL, whereas in classic Hodgkin lymphoma, you can get T-cell markers, especially GATA3, and rarely you can get CD7 and CD4 in HRS cells. What is NLPHL? As I said, like these are the lymphoma. You can have neoplastic cells as a minor population, which are called as lymphocyte predominant cells, which is short form is called as LP cells. They express the typical germinal center phenotype, the germinal center phenotype, and the background cells the cells or lymphocytes will be consist of germinal center microenvironment. Like there are 6 different architectural patterns has been described about the node depending on the architectural, and these architectural has shown to have certain kind of prognostic relevance, especially the pattern of C and E and F has shown to have a higher frequency for relapse and also transformation. So these are important to be aware of different structural variation or architectural variation in NLPHL in identifying this subtype little bit more diligently. Like how do you distinguish between sometimes you have problem poses for classic Hodgkin lymphoma, because at least 3% or 2 to 3% of NLPHL can have an EBV infection. They can show CD 5 to 10%. They can show 30 positive. But if you use an extended panel and you observe, you have this panel of markers, you can come and dissect out NLPHL from classic Hodgkin lymphoma. The reason to the importance, why it is important to distinguish, yes, it has got a biological relevance. The frequency of blast and B-cell transformation is higher in NLPHL than CHL, whereas in cases of advanced stage, the treatment protocol is different between classic Hodgkin lymphoma and NLPHL. So LP cells of NLPHL are positive for pan B-cell antigen, that is CD20 will be strongly uniformly positive, LC will be positive, 79 alpha up to BOB1, BCL6 and EMA will be positive, whereas the background cells can be positive in IgD, and they can show between kind of more germinal center. They usually negative for EBV and 15, and even if positive for 30, they can be focal and weak positive. CD15 is rarely positive in LP cells, especially in recurrent setting, and well, as I said, like 30 is weakly expressed in 5 to 10%, EBV is 3 to 5%. Unlike the Hodgkin lymphoma cells, the LP cells are typically 20 LCA up to Pax5 B cells is positive, and they are negative for T cell markers. If you want to go further, LP cells usually do not express PDL1, whereas classic Hodgkin lymphoma usually overexpress PDL1 in cases to distinguish between classic Hodgkin lymphoma and NLPHL. So you can always use the background cell immunophenotype also in distinguishing, where in background B cells have a mantle zone immunophenotype for kind of an NLPHL, and you can get T cell rosettes and the follicular helper T cell phenotype using appropriate markers and that. So I'm so sorry. So coming to, sometimes you have a problem with ALCL. It is important because they have treatment differences and biological differences, and they have challenges thrown because of the similarity in architectural and common phenomenon of strong CD30 positivity and negativity for either B or T cell markers, either both in Hodgkin and NLPHL. So in those kind of situations, yes, using an extended panel of T cell markers and ALK protein and as well as cytotoxic markers like TAA, Grange and perforin, you can use it to identify the ALCL from this thing. One aspect which I wanted to highlight is, if any of these neoplastic cells expressing B cell marker, it strongly suggests that it's a B cell lymphoma. It cannot be an ALCL. ALCL are the entities which are described for the T cell markers, either ALK positive or ALK negative. So no single marker, with the exception of ALK expression, supports ALCL, which is actually, if you get an ALK positivity, it actually excludes the possibility of Hodgkin lymphoma. However, it does not exclude the possibility of B cell lymphomas. We will come to those entities in subsequent slides. So it's recommended to use an extended panel to identify appropriately and distinguishing classic Hodgkin lymphoma from ALCL. Whereas regarding with other T-cell lymphomas, yes, sometimes you have a problem with other PTCLs, especially AATLs, because they have these pleomorphic cells which can be exactly like Reed-Steinberg cells. Yes, using a pan T-cell markers and FDC markers as well as follicular helper T-cell phenotype markers, you can identify these entities clearly. When you have a follicular T helper cell phenotype that is like positivity of at least 2 markers of CD10, BCL6 or PD1 in CD4 positive cells with expansion or proliferation of follicular dendritic cell network, it is a diagnosis of AATL. Usually, or most of the instances, classic Hodgkin lymphoma does not show any kind of follicular dendritic cell proliferation. So that might be a marker which you can use it to identify or finding or coming to the arriving into the diagnosis of T-cell lymphomas appropriately. So that is about your classic Hodgkin lymphoma, and we're coming to the high-grade mature B-cell lymphoma. This is a kind of a tricky, much more difficult areas because it requires more additional or ancillary techniques to use it. If you go into the WHO current classification, high-grade mature B-cell lymphomas are into 3 broad categories. One is DLBCL, NOS, and the specific subtypes of large B-cell lymphoma, and high-grade B-cell lymphoma. Essentially, if you have to come to a diagnosis of DLBCL, you need to go from the down, excluding these entities and come to this DLBCL NOS. That's what this picture like. First, if you have a high grade, first you need to rule out a high grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement, or is it a high grade B-cell lymphoma? NOS, once you exclude these, you need to exclude these specific subtypes of DLBCL, then only we can arrive into a diagnosis of DLBCL NOS. So what we have done, like, what is the areas which we have to discuss? Yes. Which are the areas which is the treatment or management important? Yes, which is for our clinics, we need to know, like, to identify DLBCL, NOS or subtypes versus a high-grade B-cell lymphoma by high-grade NHL as either a double it or a triple it, or high-grade NHL, NOS or Burkitt lymphoma. These 3 entities are important because they have a different treatment, prognostication differences, and also management differences. Other area is like, some cases like, about DLBCL, NOS versus specific types, especially in a medicinal location. Is it a secondary involvement of the systemic DLBCL or a primary medicinal B-cell lymphoma? Or a EBV positive DLBL, and a case of recently identified as a large B-cell lymphoma, the IRF4 gene rearrangement. Few CD20 negative B-cell lymphomas like Plasmablastic and ALK-positive large B-cell lymphomas. And the last area which we'll touch about DLBCL, cell of origin subtypes. WHO, the current classification, has recommended or suggested this flow chart to use it to come for the diagnosis. Like, if you see the morphology, when you have a typical morphology of DLBCL or high grade, any of this picture, you are supposed to evaluate these cases by FISH for both c-MYC, BCL2, and BCL6. If any of these lymphomas, except lymphoblastic or a known follicular lymphoma or a kind of known transformed lymphomas, any de novo high-grade B-cell lymphoma demonstrating any of these 2 or 3 oncogenic alterations, they should be termed as like double or triplet lymphomas. Whereas where you don't demonstrate these alterations and you have a typical morphology, if you large B-cell lymphoma, it should be DLBCL NOS, and if you have a blastoid morphology without these alterations, it should be called as high-grade B-cell lymphoma NOS. Burkitt lymphoma is a typical morphology. If you can demonstrate a c-MYC alteration, it should be called as Burkitt lymphoma, and we'll go to the Burkitt-like lymphoma as well. So when it comes to the double or triplet, that terminology in the conventional form should be termed as high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 arrangement, which is double or triplet lymphoma. Mind you, this double and triplet lymphoma is like inclusive of MYC. So in cases of no MYC, and if you have any other 2 oncogenic alterations, those tumors should not be called as a double or triplet lymphomas. So these are especially retained for only these tumors because the data from other molecular alteration not very much available to us to have a clinical connection. So currently, only those tumors which are having MYC and BCL2 and or BCL6 translocation are considered among double and triplet lymphomas. And this is classification essentially applicable for de novo cases and should not be used for the transform cases. For transform cases, you can always say like high-grade B-cell lymphoma, c-MYC and BCL2 rearranged, transform, you can put it, but you cannot use as a de novo cases. Yes, the problem with these cases are these can have a morphology like diffuse large B-cell, it can have like Burkitt-like or an intermediate morphological pattern. So that is why you need to subject all these tumors first for these cytogenetic evaluation for these markers to identify this. You have to understand that immunohistochemistry for MYC and BCL2 protein cannot be used as a surrogate, though overexpression of these two markers are called as a double expressor and also shown a worse prognosis than without the overexpression, but these are not surrogate for the doublet lymphomas. If we can put it in that way, we can say that most doublet lymphomas are double expressor, but not the most double expressors are double A. So majority of the double expressors are activated subtype and do not harbor any kind of translocation. So as of now, there is no morphology or IHC pattern which can be used as a good predictor to or screening purpose for evaluating for cytogenetics for c-MYC and BCL2 and BCL6. As for the current WHO classification, you need to subject all de novo high-grade B-cell lymphomas for these alterations to classify whether doublet or not. Only if after excluding the doublet, we will reach to the other entities of high-grade B-cell lymphoma NOS or DLBCL NOS. So why it is important to identify? Because they're very aggressive, they're known higher frequency of involvement for CNS, and worse poor response to conventional or first-line chemotherapies of R-CHOP, median survival has shown to be very poor than the conventional DLBCLs. These are the few other studies which are quite old studies which have shown that very poor response of to doublet lymphoma to R-CHOP may be requirement of an higher or a more intensified therapies which may be elucidated in the subsequent panel discussion. The same post-relapse survival is also miserable in different studies they're shown. So because of the strong clinical evidence of worse prognosis and poor responders to the common frontline therapies, this is recommended to identify upfront and treat it appropriately. So after you rule out the doublet lymphomas, you have left with either is it a bucket lymphoma or a high-grade B-cell lymphoma or a DLBCL. So when you have a kind of a morphology, not like more like Burkitt-like or Burkitt, means not a typical large cell or immunoblastic, centroblastic, and more of monomorphic, little bit of variation, especially in an adult population, you subjected for both c-MYC, BCL2 and BCL6 and not demonstrated any of the alteration. It is those entities which should be left as high-grade B-cell lymphoma. Essentially, these are blastoid morphology tumors. This is what the entity which used to be in the previous classification used termed as high-grade B-cell lymphoma, which features intermediate between Burkitt-like and DLBCL. Mind you, here you will have some cases of DLBL having on single alteration of MYC gene or BCL2 and or BCL6. These cases should not be called as high-grade B-cell lymphoma. They should be called with DLBCL if they have typical morphology of DLBCL. Only if they have a blastoid morphology, they can be kept called as high-grade B-cell lymphoma NOS. So Burkitt lymphoma, nothing great, nothing changed much about the diagnostic criteria. Only thing is they are you have a typical morphology of monomorphic intermediate size blastoid morphology, typical phenotype of germinal center type without having expression of BCL2, and if you get EBV positive or without EBV positive, it's a typical and characteristic c-MYC translocation you can use as a Burkitt lymphoma. One more addition of entity is a Burkitt-like lymphoma with 11q aberration. Yes, this has been dissected out from the subsets of the Burkitt lymphoma which were c-MYC negative. It has been found like there was kind of a gains in the kind of the 11q loci of 22. It's shown that these tumors have a similar clinical and every management profile like a Burkitt lymphoma, but they don't have the MYC translocation. These tumors have been segregated as Burkitt-like lymphoma 11q aberration. However, in the clinics, it is not important to identify this subtype because they do have all kind of features similar to a Burkitt lymphoma. So this is the typical picture. This is a pathologist, like subtle variation in size, you should start suspecting, and if you can't demonstrate a MYC translocation, probably you're dealing with a 11q aberration. Coming to why is important to identify high-grade B-cell lymphoma NOS? But what is the problem if you call like Burkitt or Burkitt-like? Yes, it is important. Why it has shown high-grade B-cell lymphoma NOS has poorer response or poorer prognosis than the Burkitt or Burkitt-like lymphoma. And the treatment protocol is also, they have shown like poorer responders than Burkitt lymphoma. Long-term prognosis of Burkitt lymphoma is good as compared to a high-grade B-cell lymphoma NOS. Here, I just wanted to emphasize one fact, one aspect is in cases of pediatric population, if you have a Burkitt or Burkitt-like morphology, there is no need to evaluate for mixing BCL2 and BCL6 gene rearrangements because the kind of high-grade B-cell lymphoma NOS are not known to be in pediatric population. Pediatric population, these lymphomas are usually of simpler karyotype, whereas in adult they have a complex karyotype. That's what characterizes in high-grade B-cell lymphoma NOS. Whereas in adults, you can, if you have a Burkitt-like morphology and not a typical Burkitt immunophenotype and absent MYC BCL to BCL6 gene rearrangement, that those are the ones entities which should be called as high-grade B-cell lymphoma NOS. So if you go by the flow chart, we have come across the ruled out Burkitt lymphoma, double-hit lymphomas, high-grade B-cell lymphoma NOS. Then we come into the spectrum of the DLB. I'm not touching upon lymphoblastic because lymphoblastic are non-mature. You can pick it up by immunohistochemistry by using a blaster markers of TD2 and CD3. So DLBCL, if you go about this, there are two major. One is the DLBCL NOS and the specific entity. To come to a diagnosis of DLBCL NOS, you need to exclude the typical or specific subtype before you come into it. So it is not, here I am not going to touch about all the specific types, but we will be touching about few types which is clinically relevant where we can want it to use. One is PMBCL, which we talked essentially much in the Hodgkin lymphoma aspect. Here I just wanted to emphasize the fact, like for a clinical side, we need to be vigilant about your clinical presentation. Like, most of the time PMBCL are present with mediastinal and supraclavicular load involvement or the regional nodes. Distant dissemination is rare at front, but maybe in case of metastatic or recurrence, you can get it. But even then, bone marrow involvement is usually absent. So when you have a distant dissemination, the challenge is whether it's a PMBCL or a systemic DLBCL secondary. You can advocate to appropriate panel to identify. Presence of typical pattern of fibrosis is important. Is it reticular or alveolar pattern? That's important. And IHC panel, if you use B63 and GETA3 in the extended panel, you will come to an appropriate test. This is few of the pictures, like cases like you have a typical reticular pattern of fibrosis and alveolar pattern of fibrosis, and you have a 23 positivity. Most of the cases they show P63 positive and negative for GATA3. In that case of typical phenotype, you will call for PMBCL because it has got a relevance in clinic and treatment, deciding about the first-line chemotherapy regimens. So when it comes to the entity of EBV positive diffuse large B-cell lymphoma, this entity may not have a great role in deciding about the first line of chemotherapy. However, it is very important in prognostication, especially in elderly patients. Elderly mean beyond the age of 40, not exactly like it has shown a very poor prognosis in patients more than 45 years of age. How do I identify these lymphomas? Yes, there are certain areas are there which you can have a suggestion, especially if you have an angioinvasion and areas of geographic necrosis. You can find a certain amount of CD30 positivity is there. You can suspect about EBV. Then you can use both either EBV, LMP or EBER. EBER is more sensitive. You can identify that EBV positive. However, a caution need to be exercised when you are dealing with an EBV positive lymphoid proliferation in mucosal sites, because EBV mucocutaneous ulcer is more commoner and DLBL, which is a relatively self-limiting disease, whereas EBV positive DLBCL is an aggressive disease. This is one of the picture. What you have to understand is when you are doing EBV, you need, in a case of EBV positive DLBCL, in addition to the neoplastic large cell, there are some small cells also will be positive. And here it should be more than 50% of the cells or predominant population of cells should be EBV positive and should be positive for B-cell, pan-B-cell marker. Then only we'll make a diagnosis of EBV positive DLBCL. This is one of our case to show that 20 positive across, 20 strongly diffusely positive. LCA is positive. You can see LCA positive with retained BOB1 expression. 30 can be positive. This is EBER-ish, and small cells are also seen. You can see this is one picture of EBV positive DLBCL. So another recent entity for large B-cell lymphoma, the IRF4 gene rearrangement is important. Why is it important? Because it's a high-grade B-cell lymphoma, usually presents in low-stage disease and also good favorable prognosis. What is important? They can have a diffuse architecture. They will have they can have a follicular architecture. So importance of identifying this subtype in a case of diffuse architecture to distinguish from DLBL because of the favorable prognosis, and in clinics you can prognosticate the patients accordingly. In cases of diffuse follicular pattern, it is important to distinguish from pediatric type of follicular lymphoma because usually this is seen in younger adults and they're more commonly seen in the head and neck region involving the Walder's ring, and treatment wise there is no difference, but of course prognostication is different. What is the typical when you will suspect? Yes, we can have a nodular architecture, diffuse architecture. They don't show a typical blastoid, neither centroplastic morphology, but a typical immunophenotype of both CD10, MUM1, and retained B-cell markers, B-cell6 positive in the high. These are the typical markers. You can subject for the fish or gene rearrangement where you can demonstrate the gene rearrangement in IRF4, which is a typical diagnostic of IRF4, large B-cell lymphoma of IRF4 gene rearrangement. Well, coming to the spectrum of those B-cell lymphomas which are CD20 negative. So how are you identifying the 20 negative? Yes, either if they are demonstrating a plasmacytic markers or kind of PAX5 or any of the B-cell transcription factor, these are all CD20 negative NHL, which they usually, most of the time, they usually demonstrate plasmablastic or immunoblastic morphology. Essentially, this spectrum is important to identify because in these cases, the conventional first line of R-CHOP maybe may not help it. What are these entities? Like one is the common is ALK-positive large B-cell lymphoma. The others are plasmablastic, primary effusion lymphoma, HHV-8 positive DLB-cell. These are essentially seen in immunosuppressive patients. Importance of identifying ALK-positive large B-cell lymphoma because it should not be diagnosed as ALK-positive ALCL. So, appropriate panel of including 138 MUM1 and EMA and CD30 will help you identify. The big difference or the major difference between ALK-positive large B-cell lymphoma and ALK-positive ALCL is CD30 positive. The CD30 positivity in ALK-positive ALCL is very strong and diffuse, uniform, whereas in ALK-positive large B-cell lymphoma it is focal and weak. So if you use an appropriate panel, you can identify this. This is one of the common entity which can get misdiagnosed as plasmablastic lymphoma because of not having ALK1 in the first line of panel. If you don't have a strong suspicion, you miss it out. So whenever you have a lymphoma of a plasmablastic or immunoblastic morphology and you don't, if your CD20 is negative, it is important to screen it out with ALK. ALK has to be done. Most of the instances, the ALK will be cytoplasmic granular positive. Rarely it has been shown to nucleus. So other entities which need to be distinguished is from the plasmablastic lymphoma, where ALK1 will never negativity. So for distinguishing from ALK-positive ALCL, yes, you can use a CD30 as a robust marker for it. You have to understand like MUM1 can be seen in positive in both ALK-positive ALCL as well as ALK-positive large B-cell lymphoma. So basing on MUM1 positive thinking is a plasmablastic differentiation, you might fall into a trap. So having an ALK in the panel on CD20 negative plasmablast or the immunoblastic morphology is important to identify this entity as this. Your plasmablastic lymphoma, yes, you will have a clinical information of immune suppressive condition, and most of the time they're extra nodal. So whereas ALK-positive large B-cell are the nodal, and this is usually ALK negative, and some form of underlying immunodeficiency can be demonstrated. Yes, reports are there of not plasmablastic lymphoma in non-immunodeficient patients also. Here it is important, like you should not make a diagnosis of plasmablastic lymphoma in cases of plasma cell or multiple myeloma where you're having a plasmablastic morphology. There it should be like plasmablastic myeloma. So in those instances also you need to have a good clinical correlation, like, you know. So this can be used as a good marker. So sometimes plasmablastic lymphoma can have CD30 positivity and EMA can be positive. Should be beware of, and I'm not calling it as ALK negative ALCL. So you should have 138 positive, 20 usually negative, or maybe focal or weakly positive. So other entity which is HHV-8, I forgot to mention one more thing is plasmablastic lymphoma. Most of the time EBV positive. If you use EBV, you can pick it up like. So other entity which is I'm not listed here because we don't come across the HHV-8 associated DLBCL, HHV-8 positive DLBCL NOS in HIV setting. They are HHV-8 positive and they are usually EBV negative. So that's how you can distinguish from PEL also, the primary effusion lymphomas, where both EBV and HHV-8 are positive. So when you have this spectrum of lymphomas in a CD20 negative, these kind of cases, it's important or recommended to include plasma cell markers 138, MUM1, 30, ALK, EBV, LMP, or EBERISH, and HHV-8 in the IHC panel. So if you use this panel in addition to the common panel, what you can come to a proper entities, which is important clinics in the clinic center. So after you rule out the specific relevant entities, you come to the DLBCL NOS. You must be wondering why I should take so much time to come to the DLBCL NOS. Yes. So when you want to use some subtyping of DLBCL NOS as a GCB or germinal center subtype or non-GCB or active subtype, it should be done only in the DLBCL NOS subtypes. It should not be done in other specific entities. So when you are using this subtype classification, first you need to rule out the specific subtypes and come to this NOS category, then you do it. So the best way of subtyping is like, you know, kind of a high throughput gene expression profiling or a low density gene expression profiling, the best way. However, IHC has been shown to be a good alternative, but in the absence of GEP, you can use IHC as a method to subtype as shown. So why it is important? Yes, ABC or a non-GCB subtype has shown to have a worse prognosis than the GCB type. What are the two common algorithms which we used? Hans algorithm and Choi et al. Algorithm has been used to, but both these algorithms are binary types, like they define either GCB or non-GCB without having any unclassifiable subtypes. So the importance of identifying the GCB and non-GCB is like it started because of the promise which has been shown by lenalidomide. When it is added to CHOP, it has shown to a good prognosis in ABC subtype, especially in phase 2 trials, which has been shown and to be better. However, the same thing could not be reproduced in the phase 3 trials. So as of now, they may not have great deal of treatment or implication, but it still has a prognostic implications, like when you're doing cell of subtype, this thing. So coming to the T-cell lymphomas, yes, you have PTCL, identification of some molecular subtype if it is possible, and distinguishing AITL or nodal T-cell lymphoma with TL follicular helper phenotype, as because you have some kind of first-line treatment decisions to be made, whether to add certain drugs or not, and especially about ALK-negative ALCLs and in areas like systemic ALK-negative ALCL or primary cutaneous ALCL. Well, PTCL, I don't want to go. This is one of the commonest type of T-cell lymphoma. They are very heterogeneous. To identify that, you need to have use and pan T-cell antigen marker and use it. So, however, there is no significant prognostication or treatment implications in subtyping further of 4 and 8. Whereas, if you do this, like when you have a diffuse CD8 positivity, we need to have a warning sign to rule out the possibility of NK cell or any other cytotoxic profile. You can add an extended panel of cytotoxic markers as well. You need to understand that can be CD30 positive, where you can demonstrate, it will be erroneous to be called as Hodgkin lymphoma. Only when you have a CD30 diffuse strong positivity, we should entertain a diagnosis of ALK-negative ALCL. But in case of focal weak positivity, the PTCL should not be called as ALK-negative ALCL. You have to be saying that you should aware that you can get EBV positive cells in background cells in PT cells. So EBV positive T cells should not negate the diagnosis of PT cell lymphoma, and also important in identifying this. So if you have two molecular subgroup which can be used by molecular, you may not be able to, but if you use GATA3 positive is a bad molecular subgroup of PTCL and has shown a worse prognosis. And once you have arrived to a diagnosis of PTCL and OS, you can use GATA3 to identify this subtype further. Well, coming to the AITL, yes, we have stressed upon in the discussion and Hodgkin lymphoma area. AITL and T follicular helper cell subtype of T-cell lymphomas are unique in the sense they have a typical phenotype of T follicular helper phenotype, which can be detected by using the panel of CD10, BCL6, and PD1. These any of the two markers coming positive in CD4 positive cells are like follicular helper T cell. With follicular helper phenotype, and if you demonstrate expansion or proliferation of follicular dendritic cell network, the entity of AITL is there. Why it is important to identify AITL? Because AITLs are the ones which are associated more often with other kind of systemic symptoms and other, you can put it as immune-related dysfunction. And so there may be a role of adding an immune modulated drug to a chemotherapy regimen. So AITL. So when coming to the recent update, what it is, yes, they have clubbed follicular T cell lymphoma, AITL, and T follicular under the common umbrella of nodal T cell lymphoma, T follicular helper phenotype, because they have shown a similar clinical behavior kind. What are the markers? You can use an panel markers, but at least two markers need to be positive to call as T follicular helper phenotype. ALK-negative ALCL, this is uncommon, but it is important for these entities to be used, to be detected by using CD30 as a marker. CD30 should be diffusely and strongly positive for ALCLs, and for both ALK-positive and ALK-negative, the morphology is usually similar. Only the one marker difference is ALK-positivity says it's ALK-positive ALCL, and ALK-negative is ALK-negative ALCL. Most of these cases are associated with cytotoxic properties, so which can be picked up by using Granzyme, perforin, and TAA antibodies, and it's important, like when you go into it, in the areas of skin lesions, it's important to know whether it's a primary cutaneous ALK-negative ALCL or a secondary involvement by systemic ALK-negative ALCL. So typical phenotype markers, like when you have substantial properties like in the positive for EMA, you can use clustering molecule, which can be used in ALCL, which is positive in ALCL but really positive in PTCL. So when you have a problem in cases of distinguishing between PTCL and ALCL, you can use CD30 is the most robust marker. If you have the additional availability of clustering, that can also be used in this. So So ALK negative AL cells should be emphasized on the CD30 expression. So if a large cell lymphoma of large B cell phenotype shows strong homogeneous CD30 expression, especially with Golgi and the membranous pattern with negativity for ALK1, it should be classified as ALK negative AL cell. That's where. So when you say ALK negative AL cell, what are the symptoms? It can be a primary systemic ALK negative or primary cutaneous cells. So in case of primary cutaneous, it's important to have, because ALK primary cutaneous ALCLs, ALK negative ALCLs is much better prognosis than the systemic ALK negative ALCLs. So what we should do, we should have a good clinical inputs there, where by primary cutaneous lymphoma, most 80% of the time they're limited to the skin with no extracutaneous disease. Typically they are like ALK negative, EMA can be, EMA is also negative, whereas systemic LCL, ALK negative LCL, at least 40-50% of cases are EMA positive. So they are usually older patients, they are usually solitary lesion, and they're very favorable localized. So many times it will be challenging on histology to distinguish systemic ALK negative ALCL from cutaneous ALCL. However, a good correlation will help you to arrive at a defined entity about identifying this. There's a panel of markers. Somebody wants to know, you can use it, but believe me, most of the time, histological or immunophenotypically, it is very difficult to identify further. It's a good clinical input, or a good friendship with the oncologist will help you in this thing. So this is just a flow chart to end this, like, say that when you have a large cell lymphoma with anaplastic morphology, first determine whether a B cell or a T cell, because not always anaplastic morphology are ALCL. If you have a B cell, it can be anaplastic subtype of DLB cell. When you have a T cell, first marker should be 30. In case of 30 negative, it should be called as a PTCL NOS. If it is 30 positive, and in case of cutaneous, either it can be a cutaneous ALCL or LYP lymphomatous papulosis type C, or it can be and if it is ALK positive, it is an ALK positive ALCL or ALK negative ALCL. Regarding a state one line between primary cutaneous ALCL versus lymphomatous papulosis type C, it's almost indistinguishable on histology. For identifying, separating these two entities, it's very important to have a good clinical backup about saying, because typically lymphomatous papulosis will have waxing waning progression, they will have this, whereas ALCL will not have it. And however, both these entities have a good clinical favorable prognosis. With that, I missed out the slide and the summary. So with that, I'm happy to take any questions if it is allowed, or maybe later.
Yes, thank you
just
so
much.
Just
to summarize this talking, I just wanted to say that, it's important to be aware of these entities and appropriate judicious use of IHC at a certain relevant situations, and also talking to the clinical side will help you in unraveling this complex, certain challenging situations. I sincerely thank you, sir, and I apologize.